In today's session, we are going to take you through management of hypertension. In the previous video, we looked at the causes of hypertension, what it is, and the complications, plus a little of treatment. But in this session, we want to go into details of how we can manage hypertension. And as you know that hypertension is one of the leading causes of death in the world according to WHO, which is a non-communicable disease. So how can we manage patients who have got either secondary or primary hypertension? And as we begin, we always urge you to subscribe if it is your first time. And it is the only gift you can do to us. When you like the video, then share to many others. Let us begin. So we are saying that under management, we are going to look at the tests performed, that is the diagnosis. How do you diagnose hypertension? And we are going to look at we're going to go ahead and look at the first line treatment and how can you treat patients with comorbidities. That is what we are going to look at. So, and under diagnosis of hypertension, before we look at hypertension, as we know that hypertension is characterized, or the signs and the symptoms is palpitations. Palpitations is whereby you feel your heart beating. There is always headache, constant headache, then dizziness. Those are the peculiar signs, and sometimes shortness of breath, what we call dyspnea. So those are the signs which you can know that I'm a hypertensive patient. As we saw that it is a silent killer, especially primary hypertension. So when you're at your home, you feel dizziness, you feel headache, then you feel shortness of breath, and palpitations, that one, you feel your heart beating. Then those ones are some of the signs of hypertension. And how can we diagnose it? The first thing is measuring. We always measure blood pressure, whereby we measure both systolic blood pressure and diastolic blood pressure. And these ones are always done on two different occasions. If the patient comes to the hospital, you can always measure for the first time on both hands. You use both the brachial artery of the right and the left. Then you compare the results. Then to avoid white coat hypertension, or someone might be hypertensive because he's fearing the doctor who is in a white coat. So after like other 20 minutes, the doctor can repeat in both hands. And after repeating, we are going to see if you get blood pressure. Our goal in management is that we know that the normal person should have blood pressure less than 120 millimeters of mercury. That is systolic of less than 70 millimeters of mercury. That is diastolic. So this one is said to be normal. Then we are going to see stages like elevated. Someone is said to have elevated blood pressure when systolic blood pressure and diastolic blood pressure. So for the elevated patient, you find they are between 120 to 139, that is systolic. Then diastolic is between 70 to 89 millimeters of mercury. So these ones have elevated blood pressure. Then for stage 1, hypertension is whereby someone is between 140 to 160. Then for diastolic is between 90 to 100 millimeters of mercury. So this one is said to be stage 1 hypertension. Then stage 2 hypertension, that is whereby someone is greater or equal to 160. millimeters of mercury. This one is not 160, but it is 159. That is systolic. Then if someone has greater than 100 millimeters of mercury diastolic, that one is said to be having stage 2 hypertension. Then hypertensive crisis is whereby someone has blood pressure greater than or equal to 180 millimeters of mercury, then diastolic greater or equal to 120 millimeters of mercury. So this one has what we call hypertensive crisis, which we shall see it in the other coming video in details, how we categorize them into different. So these different results, you must not confirm hypertension on a single BP test. So you can do this one when you find it elevated. You can go ahead and do it after like 20 minutes, after like 1 hour. Then you can even do it after the week. If it remains greater than 40 here, that's when you declare someone to be having hypertension. But if it's between 120 to 139 diastolic, then 7 to 89 diastolic, that one is having pre-hypertension, or what we call elevated levels, but this one does not need treatment. This one with elevated just needs lifestyle modification or lifestyle changes, whereby you look at the diet. The aim is to reduce the weight. Then you look at the diet whereby you advise this patient who is having pressure between 120 and 139 to always eat food rich with vegetables, fruits, and grains or cereals. Then you can also look at the exercise, daily exercise for at least 30 minutes so that they can lose weight. The diet and exercise aims at losing the weight. That is for patients who have BMI. If someone has body mass index greater than 25, you are required to do that. Then other modification is that if you are taking alcohol, we also advise you to reduce moderately taking of the alcohol. If you are a smoker, we also tell you to stop smoking so that we can always reduce the chances of continuing into hypertensive stages. That is how we can do lifestyle management. After that, if you find for these ones on 2 different occasions, someone's blood pressure is greater than 140, that is systolic, then diastolic greater than 90, that one is declared to be hypertensive. And the first thing you do also, you emphasize on lifestyle change, that is increased exercise, good diet, that is great greens and vegetables, then losing weight, stopping smoking if they are smokers, stopping alcohol if they are taking alcohol. Then you can also go ahead and do other lab tests. Other tests you can perform can include, you can do urinalysis. And under urinalysis, you're looking at hematuria, whereby hematuria is the presence of blood in urine, and also you can look at the presence of proteins, that is the proteinuria. These are the 2 things can be indicator of hypertension. Then you can go ahead to do albumin creatinine ratio, and this albumin creatinine ratio should be less than 70 milligrams per millimole. This is always the goal. So you can do albumin to creatinine ratio. Then you can do electrolytes, whereby electrolytes you're looking at potassium and sodium majorly. Then you can do blood urea, nitrogen. These are some of other tests we can perform in the lab. Then the radiologist can go ahead to do chest x-ray and ECG. These ones you want to rule out left ventricular hypertension. So you can do all these tests in the lab. Depending, you are trying to see what could be the probable cause. Another peculiar test you can do is you can do lipid profile. And under lipid profile, we're interested in cholesterol. Different forms of cholesterol like LDL, HDL, IDL. Then you can also do triglyceride levels. Here we want to see if the cause might be due to elevated levels of lipids in the body, so that during management we can do the right thing, or we can give you the right medication depending on the probable cause of your condition. So these are the tests we normally perform on hypertensive patients. And these tests, as a patient or a doctor, if a patient is hypertensive, these ones are supposed to be always repeated after 6 months. And other tests you can include during prognosis or determining the disease progression on treatment. You can go ahead to do also tests like LFTs and RFTs, so that you can rule out any other organ failure. Then for the sake of the people with the opticians, those who talk about the eyes, you can also always do retinal checkup to rule out what we call retinal hemorrhage, which is always there in emergency hypertension. So these are some of the tests you would keep doing together with the lipid profile, then with the urinalysis and electrolytes, so that you can easily know the complications early, and when the complications are detected early, they can be treated for the betterment of our patients, so that we can reduce on mortality and morbidity. So these are the tests that we are supposed to be doing if you are a known hypertensive. And in case you do these tests and you find they are not improving, then you sometimes can require to change the regimen or the drug that the patient is on. For those who are in hypertensive emergencies, we cannot wait for 6 months. We can even do it after 3 months to see if the organs are responding to the regimen together with blood pressure. So this is what we can talk under diagnosis. Then let us go to treatment. Let us look at treatment. Treatment of hypertension. And treatment of hypertension depends on the stage of hypertension. It depends on the origin. If you are an African American, it will also depend. Then another third one is the comorbidities. If either you have diabetes, or you have chronic kidney disease, or you have any other condition, it will depend, as we're going to see. So those are the 3 factors that we base on to give you treatment. That is the stage of hypertension, even the age, then the comorbidity, then the origin of the patient, or the ethnicity of the patient. So after knowing those ones, the first line for African American or Caribbean, we can always, the first line treatment for these people, so long as they don't have any comorbidity, is always calcium channel blockers. So calcium channel blockers are the first line. That is amlodipine, nifedipine, which is always given orally, slow release can also be given. So amlodipine, we can always give nifedipine, and many other calcium channel blockers for African American patients. That is always the first line treatment. Also, it is also the first treatment for patients who have greater than 50 years. Elder patients greater than 50 years, also the first line treatment is the calcium channel blockers. Then you can always combine them with diuretics. But if you don't have diuretics like thiazides or thiazide-like, that is benzoflumethiazide, hydrochlorothiazide, they are always combined, can be given in combination. But if you don't have a diuretic, another drug you can give for the African American is ARBs. ARBs respond greater than ACE inhibitors because African American, they have low levels of renin. So ARBs do better than ACEs. So the losartan, the condensartan, they are better than the captopril, the enalapril, and so ever. So African American and patients who are greater than 50 years with no diabetes and CKD, they can easily be given calcium channel blockers as the first line. Then if you get patients who are below 55 years and they have no comorbidities, the first line treatment is ACE inhibitors, or you can give ARBs. But I want you to note that never give ACEs and ARBs in combination. That one, you must note it as a doctor, as a patient, or in case you are a patient and maybe by mistake the doctor has given you those drugs, like the enalapril, the captopril together with losartan or condensartan, it is not allowed to take them in combination. So you either take ACE inhibitors or you take ARBs, but not both. And these are the first line for treatment of other patients below 55 years and they are not African American. This is their first line treatment, whereby we told you for the African American, it is better you consider ARBs compared to ACEs because they are very effective compared to ACEs. That is what I want you to note also. Then if you don't have this or you want to give in a combination, you can always add a calcium channel blocker. That is if there is no cardiovascular problems. But in case of cardiovascular diseases like heart failure, like coronary artery disease, you can opt for loop thiazides. Thiazides can be given. So this is what we can look at. But in management, we talked about the stage of hypertension. We are seeing that for stage 1, that is patients between 140 to 159 and 90 to 100 for diastolic. These ones, when you are looking at them, the first thing is you can give them a monotherapy, whereby you can, in African American, we give a calcium channel blocker. You can give like 5 milligrams of amlodipine once daily, once a day. That is OD, 5 milligrams of amlodipine. That is for African American. If they are non-African American, then we can consider ACE or ARBs. Losartan, condensartan, then ACEs is captopril, enalapril can be given. Then after giving that one monotherapy, you tell them lifestyle modification, which we have looked at diet, that is vegetables, greens and cereals, that is grains. Then together with weight loss, then exercise, then quitting lifestyle changes, behaviors like smoking or reducing on alcohol taking. So those are the things we can give them. That is for stage 1. But if they are on stage 1, you do that, then you tell the patient to come and we assess again after 3 months. If we do it after 3 months and they have not changed, then we can add like a loop thiazide. We can add it there. And if we do that and after 3 months still there is no change, then we change the medication. That is for stage 1. So we are saying stage 1 hypertension, you first give a monotherapy, and for African American is calcium channel blocker together with lifestyle change. But we said for the ones of pre-hypertension, that is 120 to 140, those ones is only lifestyle. But these ones between 140 to 159, over 80 to 89, millimeters of mercury, these ones need a monotherapy, like amlodipine 5 milligrams OD plus lifestyle change. Then after 3 months, they come back. If after 3 months, there is no change, you can now add a combination of a thiazide diuretic. Thiazide diuretic can be added. But before thiazide, for African American, we can prefer ARB. Yes, we can give a thiazide or ARB like losartan, depending on the comorbidity. That is for stage 1. So the goal, the therapeutic goal, is to keep a patient's blood pressure below 140. That is the goal. The goal is to keep blood pressure less than 140 over less than 80. That is the goal. Then for stage 2, hypertension, that is between 160 to 179 over 100 to 119. So patients having this blood pressure millimeters of mercury, this one are in stage 2, and here you are advised to give a combination. Immediately you give a drug combination, whereby for African American, you give a calcium channel blocker in combination with ARB, or you can put a thiazide. That is for African American. Then after giving these drugs, you monitor after 1 month. If there is no improvement, you can add a third and keep monitoring these patients. And we said every 6 months we repeat all these tests as a way of prognosis. That is what we are talking about. So this is how we can manage stage 2 hypertension. So we want to end by looking at management of patients with comorbidities. So patients with comorbidities, either maybe someone who has diabetes mellitus, or someone who has, so comorbidities like diabetes mellitus, someone who has chronic kidney disease. So these ones, the first line treatment for these people with diabetes mellitus and CKD is we look at ACE inhibitors. That is, or you can give ARBs. But we said for African American, ARBs do well than ACEs. That is one thing we can note. Then, if you don't have these two drugs, either ACE inhibitor or angiotensin receptor blocker, you can opt for a thiazide. You can give a thiazide as a as a second option. Then later, or you can give a calcium channel blocker. That is for diabetes mellitus and chronic kidney disease. Then patients with cardiovascular diseases, CVDs, especially we can have heart failure, coronary artery disease, can have post-MI, post-myocardial infarction. These patients can be given beta blockers. Beta blockers can be drugs of choice. If not beta blockers, we can give diuretics. And followed by diuretics, then lastly we can give SCEs or ARBs. That is for people with cardiovascular problems. But people with angina pectoris, we can give a beta blocker, and then we can also give a calcium channel blocker. That is for patients with angina pectoris. can be opt for that. But with the cardiovascular problems, the first line is beta blockers, the bisoprolol, the metoprolol, the nevibrolol, labetalol. They are the best treatment depending the conditions. Then another condition we can talk about, even stroke. So for patients with stroke, you can give drugs like diuretics. Diuretics can be drug of choice, or you can give ACE inhibitors. That is with patients with stroke. Then other conditions like pulmonary hypertension. Patients with pulmonary hypertension, you can straight away give them calcium channel blockers as a first-line therapy. Then patients with pregnancy, pregnant women. In pregnancy, we can give hydralazine, you can give nifedipine, we can give alpha-methyl-dopa. These are some of the drugs used. Even sometimes esomorol, but no, esomorol is not given. Hydralazine, nifedipine, or alpha-methyl-dopa are the drugs of choice in pregnancy, and ACEs or ARBs are contraindicated in pregnancy. So those are some of the drugs you can give in pregnancy. Then, if patients have benign prostatic hyperplasia, the first-line treatment is alpha blockers, the plazocin and telazocin. Alpha-1 blockers, that is telazocin and plazocin, are the drug of choice because they have ability to reduce hypertension. At the same time, they reduce also the swelling of the prostate gland. So that's why we prefer, in benign prostatic hyperplasia, we prefer alpha-1 blockers, though they have the adverse effect of orthostatic hypotension. That is their problem, but these are the drugs of choice. So this is what we can discuss with you in this video. And as we have said, as we are concluding, that the goal, the therapeutic goal, if the patient is less than 55 years, the pressure should be less than 140 over less than 90. That is the goal, millimeters of mercury. Then for patients greater or equal to 55 years, and they are hypertensive, the goal is to keep the pressure less than 150 over 90 millimeters of mercury. Then for patients with chronic kidney disease or diabetes mellitus, these are comorbidities, the goal is to keep pressure below 130 over 80 millimeters of mercury. So these are always the therapeutic goals as a doctor you should aim at. If someone is below 55, aim at keeping the pressure below 140 over 90. If he's above 55 years, we can consider below 150 to 90. Then if he's having diabetes mellitus or kidney injured, you consider 130 over 80. That is the therapeutic goal. And always remember to do these tests regular, at least 6 months or once a year, to rule out any problem with organ damage. Thank you so much for learning with us at Medical Sciences. Hope you have gained something from this video, and always keep tuned. Remember to like the video, then share to many others so that they can continue to learn with us. Thank you so much.